Our next speaker is Dan Clauw. Dan is Professor of Medicine at the University of Michigan and Director of Chronic Pain and Fatigue Research Center. He's Director of the Michigan Institute for Clinical and Health Research at Ann Arbor. He received his medical degree at Ann Arbor. He was a resident and fellow at Georgetown, started his academic career at Georgetown before going back to Michigan. He's co-editor of Arthritis and Rheumatism and Arthritis and Research and Therapy. He's published over 250 papers, reviews, and book chapters, and he's going to give us a fibromyalgia update.
So I'm just going to resume and really now talk a little bit about treatment of pain based on mechanisms and a little bit more about non-pharmacologic treatment. So based on the two talks that you've just heard, you probably have a little bit more nuanced sense of the pathophysiology of acute and chronic pain and the fact that, especially in chronic pain, we're really starting to move away from opioids. Certainly, these are way better drugs for acute pain and for peripheral nociceptive pain than they are for either neuropathic pain or centralized pain. And again, a lot of us feel as though we're at the point now where we can start to use this information in clinical practice. So for example, if you break peripheral pain into inflammatory and non-inflammatory, I didn't make that distinction in the mechanistic slide, but as a rheumatologist, that's a critical distinction that we make. In the non-inflammatory peripheral pain, opioids are still part of the treatment guidelines for osteoarthritis. They're way down at the bottom for refractory pain, but they're there. And in fact, they are part of the guidelines for most, if you will, peripheral or nociceptive pain states. NSAIDs, acetaminophen are always there. What we're starting to see are the tricyclics and SNRIs. SNRIs in particular are seeping in. And again, we don't know this yet. There'll be data out in the next year or so about whether we can a priori predict in an OA patient, an RA patient, if they're going to respond to a SNRI or a tricyclic based on some of these phenotypic profiles that I was talking about earlier, i.e. people with higher degrees of fibromyalgia. At the other end of the continuum, there's pretty good evidence that opioids and NSAIDs don't work in centralized pain. So once you identify that someone has a centralized pain state, or for that matter, a neuropathic pain state, the data for NSAIDs in neuropathic pain are pretty convincing that they don't work. Opioids, a little bit perhaps. But again, I think that in general, nerve pain, whether it comes from the periphery or from the central nervous system, is much less responsive to NSAIDs and opioids and much more responsive to tricyclics, serotonin norepinephrine reuptake inhibitors, gabapentinoids. And I agree with the last speaker is that in general, anticonvulsants outside of the alpha-2 delta ligands, the gabapentinoids, have not in general been found to be effective in a broad range of chronic pain states, certainly not so much that we would put. So I actually don't usually use the term anticonvulsants. I usually use the term alpha-2 delta ligand to mean a specific type of drug that was originally developed as an anticonvulsant that works for pain, just as I will rarely use the term antidepressants on a slide like that, because it's important to realize that some antidepressants that only raise serotonin, drugs like escitalopram or citalopram, Lexapro, Celexa, are not analgesics in animal models or in humans. It really seems as though norepinephrine is the more important neurotransmitter. In these serotonin norepinephrine drugs, norepinephrine is the most important neurotransmitter, and there have now been a couple studies in fibromyalgia of the drug esreboxetine, which is a selective norepinephrine reuptake inhibitor, worked quite nicely in fibromyalgia. It's not available in the United States, but nonetheless, we know that a pure norepinephrine reuptake inhibitor does work in fibromyalgia, whereas a highly selective serotonin reuptake inhibitor does not work. Just for your information, the older SSRIs, because these are classes of drugs that a lot of your patients are going to be on in clinical practice. These would be drugs like fluoxetine, sertraline, paroxetine, Zoloft, Paxil, Prozac. At higher dosages than you would normally use as an antidepressant dosages, those drugs become SNRIs. Those drugs actually start to inhibit the reuptake of norepinephrine at higher dosages.